my name is Steven Messe. I'm a vascular neurologist at the University of Pennsylvania. The definition of disabling stroke that was used in the PROTECTED-TAVR trial is that you had to have a modified Rankin score of 2 or higher, and you had to have it 1 point higher than your baseline Rankin score. So the Rankin score, for a little background, is a scale of disability, just functional disability, and it's not specific to stroke. You could have disability from lots of reasons: orthopedic, cardiac, neurologic. And this just measures how well you're functioning in your daily life, whether you need help to do your activities of daily living, whether you need help walking, whether you're bedbound, requiring 24 hours of care, and even if you're dead. So a modified Rankin score of 6 is that you are dead, and 0 would be normal, and then 1 through 5 are all the points in between. So it's a very coarse scale. Each point difference is very meaningful clinically. That's been validated with clinicians and with patients as well. And so this definition of disabling stroke, having 2 or higher on the Rankin, means that you're not able to do all of your activities that you would normally do, and you're not able to care for yourself completely in the way you had before. So you have some disability. And again, it has to be more disability than you came in with before the procedure was performed. And this definition was used in the VARC Academic Research Consortium statements, which is sort of initially laid out guidelines for how studies should be performed in valve surgery, and also in the NeuroArc, which was a neurologic academic research consortium statement that specifically was addressing neurologic endpoints in cardiovascular trials. And so this has been consistent across all of these guidelines. And I think it's a reasonable definition of disabling stroke. So this trial was looking at a embolic protection device that can be used during transcatheter aortic valve placement. These transcatheter aortic valve procedures are now very common. It's generally considered the primary method to replace a valve in patients who require that. And the main concern with doing that when you place a new valve into the heart is that you could release debris that then can go to the body, and in particular the brain, but also potentially the kidneys as well. And when debris goes up to the head and causes blockages, that can lead to stroke and clinical symptoms of stroke. So the device goes into the body and protects 3 of the 4 main vessels that send blood up into the head, and that's an important concept to understand, is that it doesn't protect all the blood vessels going up into the head, and particularly the left vertebral artery is unprotected. And this trial was a randomized trial of using this device versus not using the device to show that it can reduce the incidence of stroke. That was the primary goal and the primary endpoint. It was originally approved by the FDA based on evidence that it does capture debris, which is an important surrogate for the fact that you're protecting the brain, but they wanted to prove to everybody that it reduced clinical stroke. The study showed in the end, after 3,000 patients were randomized, that there was no statistically significant reduction in clinical stroke. The numbers were different, favoring use of the device: 2.3% incidence of stroke in the patients who received the embolic protection device versus 2.9% in the patients who didn't receive the device. But that did not achieve statistical significance. But one of the main secondary endpoints that we were curious about, of course, was disabling stroke. And that was significantly different between the 2 arms. And there were 1.3% of the patients who didn't use the protection device that had a disabling stroke versus, I think, only 0.5% of the patients who did use the device. So it was a 0.8% reduction, which was statistically significant, meaning it was 95% or greater chance that the effect was real and not due to random error. And I think based on what we know about how the device works, and that this was an important component of the primary endpoint, disabling stroke, I think it's probably a real effect, acknowledging that it's a small one. And whether that's clinically important or not, I think is an important discussion to have. And I think it needs to be weighed against the cost and the safety. And the safety of it seems to be very strong based on this study and other studies that looked at safety issues with this device. And then so it's really a question of cost and whether it's worth the cost of using the device, given the modest but likely real and meaningful benefit from the protection. I think that's a very good question, and obviously we won't know for sure. There's a couple possibilities. One that I think I favor, but we'll see, is that this study was done while the device was clinically available. And so clinicians may see a patient who they deem to be very high risk of stroke, or a patient that they really like and don't want to have a stroke, or just that the patient doesn't want to go in the trial because they feel that they're high risk and they're like, I just want to use the device. And so those patients don't get randomized. And so there's a selection bias in the patients who do go into the trial, that they may be lower risk. And by some of the criteria that you can measure a patient's risk overall for this surgery, this population was not high risk. It was certainly low to moderate risk patients. And I do think that was one of the main reasons that the stroke rate was underestimated. I think what's going to be interesting then is the British PROTECT-TAVR trial, which is using the same device in the UK, where they don't have the device clinically available. And it's going to be enrolling more patients, roughly twice as many patients. I think there's more power to show whether there's a difference, and perhaps there'll be more stroke events, and perhaps show that the device is effective overall for stroke, and get an estimate of whether that effect is clinically meaningful or not. The device is clinically available, and my understanding is in the past, up to this point, it's been used in less than 20% of all cases, somewhere between 15 to 18% of cases. And I think it'll be very interesting to see how the clinical community receives this data and whether it changes practice one way or the other. Again, it's going to be balancing cost versus benefit. And I think each health system and clinician is going to have to wrestle with that decision. So again, it'll be interesting. I don't have a good handle on how it's going to be received. I know obviously people were disappointed it was a negative trial for the primary endpoint, but there is this suggestion of benefit, and I think it remains available for clinical use. So we'll see.